Hello everyone. So we have a 50-year-old man come to you complaining of fatigue and weakness for a year. Long history, 1 year. Well, he also feels tired and also find difficult to remember things. He is unemployed and lives on social security benefits. He drinks 2 to 3 beers a day and has been charged with multiple times with driving under the influence of alcohol. His parent died of old age. Well, when you look into the blood report, this is normal. HB is reduced, hematocrit reduced, RBC count reduced, MCV is increased, MCH is increased, reticulocyte count is reduced. Peripheral smear shows anisocytosis, poikilocytosis, and basophilic stippling. Next step in the management of the patient is answer is serum B12 and folate level. Why this? First of all, as in the question description, it is macrocytic anemia is there. How can we say? Anemia, yes, hemoglobin level is 7 gram. It is anemia. MCV is increased is more than, it is 114. And we know very well, if MCV is more than 100, we call it to be macrocytic anemia. So we are getting diagnosis right now here only. Even MCH is increased. That is again a feature of macrocytic anemia. Okay. So the next step in the management is look for peripheral blood film, and in this we macrocytes, which already mentioned. And reticulocyte count, it is reduced in our case. Patient smear and MCV more than 100 favors megaloblastic anemia. Now, when we are thinking about megaloblastic anemia, you like to check for B12 and folic acid, and they will help in distinguishing between B12 folic acid deficiency from other causes of macrocytic anemia. So, with low level, if the B12 folic acid are reduced, then that needs further investigation. So before I discuss more about, let's learn more about megaloblastic anemia basic concept. It typically associated with macrocyte, like in our case, MCV more than 100, like in our case, it is 114. Now, we have to see for the neutrophil, you look for hypersegmentation of neutrophil nucleus. That means then the number of lobes are more than 5 in neutrophil nucleus. Low retic count, that in our case it is 0.4%. And anisocytosis, poikilocytosis, this is seen in peripheral smear, anisocytosis, poikilocytosis, and basophilic stippling. Now, as I told you, there are non-megaloblastic anemia. That means, how do you say this non-megaloblastic anemia? When the neutrophil nucleus, the lobes in neutrophil nucleus are 5 or less than 5. Then we call it to be non-megaloblastic. Now, but in this type, of course, they are a type of macrocytic anemia. So macrocytic anemia can be megaloblastic or it could be non-megaloblastic. In megaloblastic, retic count is always reduced. But here, in non-megaloblastic, retic count may be increased, may be normal, or may be reduced, depending on the etiology. That means reticulocyte count is, if it is increased with the macrocyte, so definitely it is not a megaloblastic anemia. The common cause of macrocytic anemia, remember now, macrocytic anemia, folic acid, B12 deficiency, myelodysplastic syndrome, acute myeloid leukemia, drug-induced like hydroxyurea or zidovudine, liver disease, alcohol abuse, and hypothyroid. So any one of them. So we are in all these conditions, you will get macrocytic anemia. Pernicious anemia is the most common cause of B12 deficiency, and these patients may also develop neurological deficit and achlorhydria. Now I have certain question for you. Stop the video, write down the answer. Which features are seen in pernicious anemia in brain, spinal cord, and eyes? Write down the answer in your copy. Stop the video. In the brain, we get dementia. In the spinal cord, there is involvement of what we call as subacute combined degeneration. There is involvement of corticospinal tract, so-called pyramidal tract, and there is involvement of posterior column. They are involved in subacute combined degeneration. In the eyes, it can lead to optic neuritis. It can lead to optic neuritis. Okay. Well, blood lead level. In this, we get basophilic stippling classically. But the question is, what do you mean by basophilic stippling? Basophilic stippling that form varying size of blue granules in the RBC cytoplasm is basophilic stippling. Bone marrow biopsy is helpful in distinguishing, diagnosing myelodysplasia, which usually causes cytopenia in more than one cell lineage. Here only RBC count is reduced. TLC and platelet counts are in the normal range. Although patient can develop macrocytosis, bone marrow biopsy is usually reserved for evaluating patients with normal B12 and folic acid level. So in these cases, we first check B12 and folic acid. Direct antiglobulin test, also called as Coombs test. Coombs test we do in those cases where we think autoimmune disease is there. In autoimmune hemolytic anemias, of course, patient has anemia is there. Okay, but in this case, the anemia is in the range of 7 to 10. In our case, it is 7 gram. Retic count is to check, but in this case, usually retic count is increased. Okay, increased retic count occur, but in our case, retic count is reduced. Unconjugated bilirubin, increased LDH, increase unconjugated, increase LDH. Haptoglobin level are also decreased. Peripheral smear shows spherocytosis. So this is not a case of any autoimmune disease. Well, moreover, we do get macrocyte, but it's not usually less than 110. But in our case, it's 114. So it's not the case of so-called autoimmune hemolytic anemia. Iron studies, we get microcytic anemia. MCV is less than 80, is altogether ruled out. Golden line to remember, macrocytic anemia can due to megaloblastic, impaired DNA synthesis due to B12 folic acid, non-megaloblastic alcohol, hypothyroid and liver disease. Peripheral smear, reticular count and B12 folic acid can aid in diagnosis and distinguish between megaloblastic and non-megaloblastic macrocytic anemia. Thank you very much.